It's a stark statistic. Each year in the U.S., more than 47,000 people commit suicide. In 2017, 191 South Dakotans ended their own lives. Suicide and depression. Let's talk. Tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. When a person reaches a point in their lives where suicide seems like a reasonable solution, they are in a bad place indeed. First, let's take a look at this week's Prairie Doc quiz question, true or false. Until 1961, with the diagnosis of depression or suicide, in Great Britain it was against the law to attempt suicide because that act was a sin. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in, but we'll answer your questions about depression and suicide as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight is a great friend of the program, Dr. Matt Stanley of the Avera Medical Group, University Psychiatry Associates, Sioux Falls, South Dakota. And you just recently launched your hospital. Matt, tell me a little bit about what happened there.
Yeah, well, first I want to say thanks for having me, Rick, and always a pleasure to have the opportunity to talk to you and your viewers. But yeah, we were both fortunate and unfortunate that we were struck by a tornado. If you're aware of where our building sits, and it kind of runs west to east, so we were hit hard in that northwest corner. There's a couple of miraculous components of that, though. We had 102 patients in that hospital with about 12 minutes warning that it was even a tornado warning. Our staff was able to get all those patients into a safer area. We had 7 relatively minor injuries. Whereas if you look at the devastation where that tornado hit, I would almost guarantee if we had patients in some of those areas,
they would have been gone.
Yeah, we would have not escaped without a death. So a great response by our staff. We had a tremendous support across our state and neighboring states to be able to move patients to safe places, including our own state hospital, which opened up a couple of wings. So we're operating out of there right now, and we're able to do that within less than 24 hours.
Wow, I didn't know that.
Yeah, so we actually are operating 31 beds down there right now on adult and about a similar number on adolescent. So we're kind of spread around in 3 different areas. We've gotten 28 beds back of the 110 or so we have at our psychiatric hospital.
That are open.
That are open now. But it'll be June probably until we get the whole thing back up to where it was prior to the tornado.
You know, I've heard that it's like one of the best psychiatric institutions in the country. You know, what do you have as far as data to say quality?
Yeah.
So much over.
Well, we don't really publish this, but we belong to a group of hospitals that's called Harbor Performance Index. It's a lot of East Coast hospitals, some well-known Midwesterns. So we compare our data, outcomes, readmissions, also things like costs and et cetera. We are always at the top of that ranking, and those are some well-known hospitals, but because it's internal, I won't mention them. The other thing, Mark Koval, who is the president of the National Association of Behavioral Health Care Facilities, has visited our facility and said this is perhaps the finest facility in the United States. So both our outcomes and our visitors, Kitty Dukakis, in fact, who gets her own treatment at Mass General, said, I'm going to tell those doctors in Mass General in Boston, they need to come to Sioux Falls, South Dakota and find out how it should be done. She was talking about our electroconvulsive therapy program, but she was very impressed with the entire facility. So we're proud, hopefully rightfully so.
Well, I always thought this was a a nice mark for Avera, because it didn't look like this was going to be a financially good thing for them. It's just to do the right thing, and they did it. They put it forward. They made the best push for a good hospital, and it's worked out for them.
Yeah, and I've been fortunate to work for an organization like Avera that has never walked away from the significance of mental health in caring for the entire person. So it's not been the sexiest, not been the most profitable, but for the last 60 years we've been committed to it. The interesting thing, so I travel around now, I talk more about behavioral health issues, I talk about our facility and some of the programs that we are promoting. And there are a lot of religion-based healthcare systems out there, but I don't think I've talked to a single one that still has nuns operating on every single board and making decisions every day. So I think that's one of the reasons we really have not strayed from the mission. And I think the fact that we're now building a chemical dependency facility, which will open up within the next month or so, another example of commitment to the whole person. Do the right thing. It's not always about bottom line. It's taking care of our communities and our people here. So.
And nothing to. I am not speaking negatively about Sanford. They have done wonderful things.
Absolutely.
As
well. We're fortunate in South Dakota, and sometimes it's hard to know that about your own. How good your own backyard is, but we get to travel around, we see other places. We're very fortunate.
So we're talking about depression, and we're talking about suicide. Those are, unhappy topics. And so, of course, I think a good show is when we laugh and we are jovial. And so I'm going to push that we should be laughing and jovial, but it's a tough topic to
Absolutely, yeah. So we'll have to pick our moments there, because there's not.
It's so sad.
We don't really identify a lot of wins in this area of late, although I think there's some promising shifts. And one of the things that I think is promising, we were talking about a little bit earlier, is there seems to be a rising social consciousness around behavioral health issues, whether it's a result of the opioid epidemic, which has captured kind of the national attention, or suicide, and the fact that rates have actually risen from 1999 through 2016. Though that's not the kind of news we're used to hearing about healthcare in America. No. We're used to hearing about successes and improvements.
And hasn't the payment improved? I mean, I think there was it was in the 90s or something where they finally, the government said, okay, Medicare will pay more fairly.
Yeah, and in fact, there's a Federal Parity Act that says that, you have to include healthcare in insurance products and in payment. So, it's like anything. I think the intent is there, the legislation is there, whether it's totally applied equitably across all fields. Sometimes there's an argument there, but access has improved, and payment does exist in many cases, not in every case.
Not every case. Mental health is a very important component. In our community, they want to build a new jail, and there's been a new jail in Sioux Falls. There's jails being built. And I look at those jails and I think, who are the people that are in the jails? And many of them are just substance abuse, not bad people. They're caught and they have an illness. Yeah. And many of them have mental health issues. And instead of kind of working at trying to fix what might be fixable, we're putting them in jail. I suppose we're doing some things in jail to help them, but what's your take on that particular social issue? And then we'll move on to suicide and depression.
Well, I think you've touched on, unfortunately, what has become our default system of behavioral health care is our
jail,
our prison systems, our jails, our incarceration. So, yes, I absolutely believe in talking to our legislators and our law enforcement officers, and Chief Judge Gilbertson has been trying to make a significant effort here in South Dakota. They're aware. They have limited resources. They have limited access to psychiatry and forensic support. Again, I think there's more attention on it than ever. I think that good things will come. South Dakota, one thing I believe about South Dakota is we rarely see a problem we don't get together and help to resolve. So I think that we will make progress, but resources in behavioral health in general, providers, psychiatry is a shortage, chemical dependency counselors are a shortage, beds for recovery are shortages. So we've got some large-scale issues to resolve to try to turn this thing around.
Right. So, it's interesting that I've read recently that 1 out of every 4 women has considered suicide, and 1 out of 8 men. And in this country, 1.4 million suicide attempts occur, 47,000 deaths occur. And even though there are more women that consider it, the men are the successful. Why do you think men are the ones that end up more successful? Well, successful is not the right word.
Right.
It's more lethal in men than
Yeah, and you just touched on the proper word, lethal. The lethality of means is the primary reason we see.
Yeah.
So well over 50% of all suicides among males is accomplished by firearm. Most, it's well over 50%.
Okay.
So firearms, there is no, or rarely, a second chance if you use a firearm. Whereas with women, we still see overdose, drug poisoning as the most common means, which does often leave an opportunity for rescue. So it really, although women and men get depressed at about the same rate, and you just identified the suicidal ideation being actually more prevalent in women than men commit suicide at almost 4-to-1 rate over women. So, but it's means, which brings us to the most impactful thing you can do if you have someone who has thoughts of suicide, or if you feel someone's at risk, is what's called
get rid of the guns.
Yeah, lethal means counseling. It's restriction to that access of guns. Because the other concept we don't talk about a lot is, although people think of suicide, there's a fluidity to the intent. So I may have thought of suicide.
Fluidity of intent.
Yeah, so at 4 o'clock this afternoon, I may have been very close to wanting to do it. By 8 o'clock tonight, I may be down here where it's a concept, but I'm not really, I think I'm okay. Tomorrow, I may go through those same waxes and wanes. The problem is, if we can get that firearm out of there, that lethal means away from easy access.
When they're on the bottom of their hill.
Right. When they have that moment where it's like, nope, I'm just going to do it. If they can't achieve the access to it, there's a fairly good chance that will pass. They'll move on. So I'm not suggesting that people don't need treatment and that if we just keep them away from the means, that's the answer. But it's part of the answer.
Yes.
It's to reduce that impulsive action. There is one statistic that indicates between the idea of committing suicide and the suicide act itself is only about 10 minutes. So it's a very brief time frame. So to keep the means away is critical. Now that doesn't mean, we all know there are people that have contemplated suicide for years, but again, it's contemplation, and there's a difference between thinking of it and acting on it.
So what about the issue of a young person being more, what's the word?
Impulsive, spontaneous, yeah.
Whereas the older people think about it more, the kids are more likely to say, oh, that's a good idea, boom, and they're dead.
Well, I do think evaluating adolescence is exceedingly difficult. And we hear every year, every week almost, an adolescent commits suicide and those around him say, I can't believe he did it, I would have never believed it. Sometimes we're aware, or somebody's aware. Usually somebody's aware, and that's another opportunity, because if you have an awareness of a friend or someone else who's had suicidal thoughts, no matter what promise you've made or discussion, you don't want to break trust, but you need to say, I've got to talk to somebody about it. It's not fair for me to have to live with this in case you do something, because I care about you, man. That's why you told me.
Yeah.
So usually somebody knows, but it's so hard because it seems spontaneous. It can be, a bad grade, a girlfriend broke up or a boyfriend broke up. It's these events that, and we as adults look back, we forget how intense emotions are at that age. We say, how could they do that? That's not a big event, in the scope of their life, but it is to them. It seems incredible. The other thing that is probably a whole topic unto itself is the impact of social media and broad scale shaming or broad scale exposure of any event that happens in your life. I was talking earlier, like we are more isolated in some ways than ever, but we're less private than ever. Everything seems to be exposed.
On the social media.
Yeah.
Let's talk about more on social media after this. The lives of Keith and Deb Kraft were turned upside down after their 24-year-old son took his own life. Part of their healing journey includes sharing their story.
We lost our son to suicide December 8th, 2014. And for our experience, it was really a shock. Even his friends, his professors, people who knew him, would never have guessed that he would do something like this.
Everyone is very aware of who he is and what is going on, and it's just like, no, you don't really understand, and we need to help you understand. And so we want to be honest with people.
And I spoke at his funeral. I didn't do the funeral, but I spoke at his funeral, and I put it right out there, and I said, we're going to talk about the S word. We're going to talk about suicide. And we're going to just put it out there, because Ben did not fit what we typically think of as someone who would die by suicide. You know, Ben had his whole future ahead of him. He wasn't hopeless. He didn't come from a broken family. There wasn't alcoholism. There was nothing you could really point to, you know, especially where we live. A lot of it is when you hear suicide, it's like, oh, it's because of the hopelessness that they faced or whatever. And it's like, no, it's more than that. There's a mental illness going on there. Yeah, there's a hopelessness, but most of that is because that mental illness takes you to that place of hopelessness. I mean, again, that may sound weird, but they don't really want to die. But their mind is telling them that their loved ones would be better off without them. And it's a lie. And I think that's the hard part with mental illness. Where's that line where it's just somebody going through a funk or a bad stage, or that really serious mental illness?
Oh yes, I've been to a counselor. I was depressed, and I'm now so much better. You don't hear that from people. But if you were sick and you had had cancer and you'd gone for treatment and you were now in remission, everyone would be celebrating with you. But that's not the way that it works when we start to talk about suicide and mental illness. People kind of want to know the why. You know, and all we can do is say, we don't know why. And we have to come to grips, if you will, and that was probably one of the biggest things with grief, was realizing we would never know why. We would never understand why.
And that's the way I look at with Ben. It's a mental illness that took his life. The way he died was by suicide.
This is your program. Your questions are key to our discussion. Please, please call in your questions. This is a tough topic, but I need your questions. 1-888-376-6225, or send us an email to ask@prairiedoc.org. So Mr. Kraft said, the last line was, mental illness took his life. What's your sense of?
Yeah, well, I really appreciate that comment from Mr. Kraft, and you can't listen to that story without being touched, as occurs every time I hear folks talk about what they've lost. But he's absolutely right, and his wife also was talking about how we view mental illness differently than cardiovascular disease. You know, if you went to the cardiologist and he said, oh, you know, you had an MI, but you would be talking about it, celebrating and discussing it. I doubt if anybody's visit to me has been celebrated as much. And I'm telling you, I'm great to come visit. But so there is a couple of critical differences there. He's absolutely right. Mental illness is a disease. It will change the way you think. It will disturb your perceptions. And I'll give you an example. People, I think until you've talked to somebody mentally ill or been mentally ill to that degree, you don't appreciate how much it can change your perception of the world in an entirely incorrect way. But I'll give you the most extreme example. So people come to me with severe depression. They think they're hearing the voice of God. Now that's not necessarily what their son was experiencing, but that's an example of, if you don't think it can change the way you think about things, when your mind can be so ill and you're functioning in every other way, but you think God is talking to you or telling you that you're a horrible person, and that's at the very end of the spectrum. Up to there, you think things, as they were describing, like your family doesn't care about you, you're worthless, you're never going to succeed in things. Yeah, I think hopelessness often is a part of it, but he's also right in that it's really that disturbance of perception around you and not being able to put things in a correct perspective and really understand your worth and your value and how much your family and everyone else loves you in spite of what you're thinking.
Yeah.
That's what trips you over for most people.
So I wrote an essay for a newspaper early 80s. And I'd heard that there was a run of suicide in a small community, and it was Pierre at the time. And then we hear more about Native American kids that get into a rhythm of it and so on and so forth. And I made a point of people who are young and who are romanticizing it. Come on, get off of that. Pull yourself up by the bootstraps. Get your life going good. Well, I got some really harsh criticism.
Yeah, I can imagine.
Because this is an illness. This is not a bootstrap, type of a thing. When God is telling you that you're awful, there's something going on in your brain that's not right. It's an illness. It's diabetes of the brain. It's a heart attack going on. Something.
Right. Well, and we do need to put it in a medical paradigm. What we have is a very wonderful medical system. Everybody in this state probably knows exactly who they should go to if they have chest pain, but less than, little over half know where they should go if they suddenly experience depression. It actually, in my opinion, should be the same place, but we've got a way to go there. The contagion, that suicide contagion, is a difficult concept to understand.
These young kids all meeting at the graveyard and mourning and all that stuff.
Yeah, an interesting though, how we portray suicide does have an impact. So there is a Netflix series, 13 Reasons Why, which you've probably heard of. I think the first season was 2 or 3 years ago now, and I'm off there probably, but it was met with a firestorm of controversy, and most people in my profession would have said it was negative. It glamorized, portrayed suicide in a way that almost would potentially encourage it if it weren't well understood. Well, the NIMH, I believe it was, or the CDC came out with suicide statistics. The month that came out was one of the biggest rises we've seen in adolescent suicide.
No kidding.
Pretty straight correlation. You may or may not believe that that's cause and effect, but certainly looks suspicious. So the way we talk about suicide, and particularly I think in adolescents who are, as you stated, very susceptible to being influenced by media and perception of others. We need to, this is not a glamorous event. This is a terrible waste of a person's life.
Yes. We did talk about social media, and I want to talk about that, and we've got questions, and we also want to talk about treatment. What would be your, what do you want to do first?
Well, I'm your guest. I think that's
okay. I'll do that. Let's talk about treatment. One of the things that we talked earlier about when we were talking to our pre-professional club group earlier was that ECT,
electroconvulsive therapy, right,
has got a bad rap. Many people have heard the book or read the book, Who Flew Over...
One Flew Over the Cuckoo's Nest.
One Flew Over the Cuckoo's Nest.
Or seen the movie, which is even worse. So
yeah, and I saw them both. I mean, I was this was right in my time.
Right. I have never seen an accurate portrayal of electroconvulsive therapy on any. It's often portrayed, often poorly. So I will say ECT is not the solution for everyone, but if you have struggled with depression throughout your life and you don't respond well to medication, or you haven't responded consistently, electroconvulsive therapy is one of the most effective treatments we have in our arsenal. And depending on what study you look at, it's 75 to 90% effective versus medications, which usually come in somewhere around 40% effective. ECT is actually quicker, really isn't affected by things like your metabolism, your genetic profile. So there are some, it's a big gun, so with a big gun you often get some side effects that are larger than normal or more impactful than normal. The biggest one being concern about memory disturbance.
Yeah.
Remember, with ECT, we are inducing a seizure, so there's going to be some confusion about events of that morning or during that period of time.
I mean, that's
when
normal.
You get treatment. That's pretty normal. If you've known anybody with seizures, they're going to be confused about the event afterward. That's kind of part and parcel of seizure itself. But the good news is it's usually a Monday, Wednesday, Friday treatment. Usually it's 6 to 10 episodes, so within 2 to 3 weeks. You are hopefully recovered versus medication. We're usually out to 4, 5, or 6 weeks. So there are some benefits. It's worth discussing if you have struggled.
70 to 90% non-medicinal therapy success versus 40% with medicine.
Now the benefit of medicine is you can do different trials, and you'll eventually, for most people, find something that's helpful, at least for a period of time.
Wow.
But there are, transcranial magnetic stimulation, another option that is now up and going. So a little different. It takes a little longer to become effective, but that is more of MRI type technology, creating pulses in your left prefrontal cortex.
Right. And so let's talk about MRI therapy for depression.
Yeah.
I mean, I've heard mixed reviews in the literature when I've...
Yeah, and I think some of that early mixture was really because the studies that looked at TMS really didn't set up a protocol that was then repeated by each one. So you saw several studies that were underpowered in terms of the energy or underpowered in terms of the number of treatments. And that's kind of what we as providers first heard of. Okay, well, it's out there, but it's not that effective.
Right.
I think, the FDA now cleared it, the FDA doesn't approve procedures the same way they do drugs, but they've now acknowledged it. So, they acknowledged it at 3,000 pulses for 30 treatments. So it's much more specific and stronger than most of those earlier studies were in which it was developed.
And you've seen...
I have seen
success.
Wonderful results. A partner of mine, Sarah Flynn, does it now in Sioux Falls. I had done it for a couple of years, and we had truly much better success than I would have expected. And I would talk around that 50 to 60% range. So.
And now insurance is covering it.
For the most part, you have to have gone through some hurdles. You usually have to have failed some medication therapies, but yes, most insurance companies now are covering that.
What about ketamine? Ketamine has been thought of as a new therapy for depression.
Very interesting. So anecdotal reports again preceded evidence. The latest Cochrane review, I think, still is a little on the fence, but I've known patients that have responded. S-ketamine, the nasal inhaler, is now available as an FDA-approved drug. It's hard to do in the office. You have to be monitored for several hours after the injection or after the inhalation. The difficulty with ketamine seems to provide rapid response, but actually attenuates rapidly. So it just doesn't last
as long.
So it's being administered much like ECT, where you get boom, 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 and then you start to taper off and hopefully sustain as they spread out time between treatments.
Right. What about LSD or magic mushrooms as a therapy for depression? I mean, that's hot right now. There are books. I've read a book about it.
Yeah. Well, and because ketamine itself is kind of a dissociative drug. Yeah. It does kind of bring back in the 70s and maybe before and a little after. There was a belief that those kind of mind-altering substances would help in psychiatric interventions. Mm-hmm. I've never been involved in those studies. Those studies aren't really highly powered because most of them are illegal, and so I don't know. There is a, what would you say? There's a signal out there. I just can't tell you how strong it is or what that's going to turn into. I think the good news in this discussion, though, is there are new things that are being tried, new approaches. So we really, when we talked about antidepressants before, was working on norepinephrine, dopamine, serotonin. Ketamine now, is a very different drug, really classified as an anesthetic, as you know, and has been used as an anesthetic. But now we're talking about drugs that impact the brain in a different way.
Yeah.
So.
Well, and there's some hope, particularly for people who are addicted with certain kind of substance abuse addiction, and they've been using LSD or similar like medicines for that. But like you say, it's really early, isn't it?
It is early, yeah, and rightfully so. The FDA is cautious in approving new drugs.
Yeah. A few minutes ago, we heard the story of Keith and Deb Kraft, whose son died by suicide. They said that while their son didn't seem to show the typical signs of depression and suicide ideation, they want others to know what to watch for in friends and family members.
Not that our family is special, any more special than any family, but if it can happen in my family, our family, it can happen in any family, and it does happen in any family. As far as the family members, especially like grandparents, is aunts, uncles, pay attention to their moods, their habits. If there's a change, if there's a real change in what they're doing, if they're really happy and now they're sad, or
They're sad,
even
then
worse, if they've been kind of in this depressed mood and then all of a sudden they're really happy, sometimes that's a sign they've made a decision to take their life.
Ask that question, but part of the reason we don't ask that question is because we're afraid. We're afraid of the answer, and I think about that. Should I have asked some of those questions? And I think that's, so I do think, it is good to say, are you okay? It is good to say, do you have a plan? Ask, is there someone you can see? Is there someone you trust? I think those are important things to ask.
I think one of the worst things we can do is be in denial of the mental illness. Oh, that can't happen to my son, my daughter. Just power through it. We don't understand. It's like we need to accept what they're going through and support them through that. And again, like I was saying, for me, be there for them. Take them to you're dealing with this. You know what? I'll go with you. I will take you and sit with you and hold your hand while you're waiting to go in, whatever it takes. But mainly is just don't
minimize it.
Don't minimize it, and don't deny it. Yeah, don't just say, well, life is worth living, so don't think those thoughts. But to me, suicide is a combination of two things: a mental illness and a stressor. And the stressors can be just common everyday stressors. For Ben, it was, I've got a girlfriend, how does she fit in? I'm going to graduate. What do I do with the rest of my life? This is something every college student goes through. But when you combine that with a depression and an anxiety, and it's at a bad place, the two combinations are lethal. And so to me, the key is, how do you do it? How do you find that before you get to that, I'm thinking about taking my life? People who have lost loved ones and people who are dealing with mental illness, you're not alone.
If I can help someone to not have to experience what I've experienced, then it's worth whatever we do, because it isn't something you want someone else to experience. And so if we would allow students to just acknowledge, or people to just acknowledge that, yes, I don't feel well, I'm mentally depressed at this point. I'm thinking about suicide. If we weren't afraid to talk about it, we would have people who would be able to go on and live whole lives.
We so much appreciate the craft people realizing that one of the solutions to recovery is to jump in and help fight the fight. Writing a book was helpful for me with my cancer. Mm-hmm. And so there's, jumping in and getting involved is very important. They were talking about the different causes, or put it this way, risk factors. And my list includes family history, prior experience of depression or manic depression, of history of being abused or being an abuser. We can talk about that. Excessive use of alcohol, sleeping pills, substance abuse, emotional loss, recent medical illness. And putting what they said and that together, what do you think has been your experience with risk factor? Sometimes nothing?
Right. So one of the difficulties with risk factors is, although they can make us more aware of someone having a risk, they're not very specific to any individual. So I can look at a list of risks, and you and I could have the same risks. You may actually be at risk for suicide, where I may not. So they can be somewhat. They can raise a level of awareness, but they're not very specific to who is and who isn't truly at risk. So all the things you said are accurate, and what the craft said is absolutely accurate as well. I think one of the messages that I love that they are promoting is this idea that we still operate under stigma. We're not willing to talk about it. A young man doesn't come to his folks and say, "Mom and Dad, I've been kind of depressed. Should I get some help?" Unlike, if he's got, I've had this pain in my chest, or I think I've been sniffling for a week, Those are things we're more than happy to talk about. And when we go to our doctor, is he asking us if we had depression? More and more, yes. The answer is yes. But we have a long way to go.
That stigma is a bad thing, isn't it?
Yeah, and we have to get past that. The idea that somehow mental illness and physical health are two different things. It's one body, it's one mind. They are interrelated, and you rarely see one occurring without the other being in play. Just as an example, I'll tell you, so we're going through a farm crisis. We know that. We're very aware of it in this state, the entire Midwest, the entire country. But we have seen this before in our behavioral health center at Avera. We talked about, well, how are we going to reach these folks? Because talk about an independent, self-reliant, I will pull myself up by the bootstraps. I don't need anybody help. That's what you're talking about when you're talking about farmers and ranchers.
Yeah, we have a graphic actually. There's the number.
Absolutely wonderful, because one of the things we said was, well, how do we reach them? Well, we need a 1-800 24/7 hotline. It can be anonymous. Nobody will know. They could be doing it from the cab of their tractor. They could be doing it from the cab of their pickup. All they got to do is pick up their cell phone. Because the problem is we're still embarrassed to go and ask for help about this. And quite honestly, that farmer doesn't want his pickup seen in front of the local mental health center.
No, they don't.
So we have a long way to go, and I think that when we get to that point, things will be remarkably different.
And I begged for questions, and then I haven't touched one of them yet.
All right, let's get to those.
I'm such a bad guy. So quickly through the questions, if we can. In regards to the red flag law in South Dakota, and I'm not aware of that, do you think those who are mentally unstable seeking help are discouraged from calling in fear of losing possession of their firearm? Explain the red flag.
Yeah, and I do believe that that's the red flag on the, you have to do the paperwork to get a firearm in the state of South Dakota. And if you've ever been committed, or if you've been identified to having a persistent mental illness, you are excluded. So I would say, I think there is some concern about that. And I understand what that person is saying. I'm not sure what the best answer is for that particular problem, because we identify that many of these shootings are mentally ill folks, but there's many shootings that aren't mentally ill folks. Most of the data would indicate mentally ill are not more dangerous than non-mentally ill.
Right.
So
Do you have any statistics on anyone that takes someone else's life and then commits suicide?
Boy, I don't, but that always shocks me, and I'm in this field. So I have never fully understood that. I don't have the statistics. We've had a couple of unbelievably traumatic cases right here in South Dakota.
Where they've killed their family and then they killed themselves.
I have, yeah. That is one of the most unnatural acts in humanity, and so.
No good answers.
You know, so you think of like Andrea Yates, which was a very famous event at its time where she was trying to drown her children or drown her children. She was severely mentally ill and under the influence of delusions and psychosis. That I can somewhat understand. I mean, it doesn't mean I certainly don't condone it, but I understand how you could be so ill you would do something completely out of character. But in some of these cases, it doesn't sound like they were that ill, and that I just can't relate to that.
I can't relate to it either. A caller has been told that it might help someone who is suicidal to be asked to look to the future. Have you found it to be helpful for a friend to set up a meeting appointment to see their suicidal friend at a future date?
You know, one of the things we do try to look for.
That's interesting.
Yeah, one of the things we look for in a protective factor is, do you have plans for the future? Because if you've set a date or if you've got in your mind that I won't be here anyway, that's an incredibly high risk sign. So rewording that a little bit, we do look for people that have some intent to do something in the future, plans for the future as a positive. So what they're saying is, if I get them to make that plan as a protective, it's an interesting twist on that.
Yeah.
And I won't say that it doesn't help. I think just being a close friend probably helps, and trying to be there and supportive is incredibly important.
I really think having a good friend to lean on is important, but that good friend needs to make sure that other people know that this guy is at risk.
Right.
A caller has been told that it might help. Any studies about that, by the way?
That what might help? I'm sorry.
Circadian rhythm. So,
circadian rhythm I think is incredibly important.
Are there studies of circadian rhythm
Yes.
correlated with low points of depression? Sorry.
Yes, so often our sleep-wake cycle is one of the things that's disturbed, and remarkably so. And I think for people that have chronic depression or chronic mental illness, to be attentive to their circadian rhythm, again, talking about the fact that the mind and the body are really one, we kind of artificially separate them. But we've talked about exercise on your program before, so I wouldn't say that any of these things are curative, and I don't mean to imply that if you take care of your body, your depression will go away. But it's helpful. It is helpful.
It helps.
Go to bed at the same time, get up at the same time, try to be attentive to that.
Yeah.
Rest, sleep is the most restorative act of the body, so if you're going to recover from any illness, including a mental illness, it will help.
I will also say that we know that low vitamin D is a risk factor for all-cause mortality, but giving vitamin D supplement doesn't seem to change it. But the sun does. I'm looking at your suntan
I love
on your
the
hands.
sun.
So I'm thinking I've pushed people away from the sun all my life, and I'm changing my mind.
Well, here's
on
our dilemma. Oftentimes what we've been preaching for years, somebody tells us in a study, that's bad, and we're at lost.
And
loose ends.
I just lost my computer here.
Well, one of the things we were talking about, and one of your staff mentioned that she had just read a story that teenagers, 10
to 14-year-old girls.
Well, that's the highest, that's the most rapidly accelerating demographic for suicide, which is frightening. When I was in training 25 years ago, I don't know that we had very many 10-year-old girls that came in with suicidal ideation. So 10 to 14-year-old women, girls, has the highest increase in suicide rate of any demographic, and it's something like 400%. So it's still not a large number, but the fact that we're even seeing it is frightening. What's going on?
Who thought of it at 10 to 14-year-old tripled? That's crazy.
It's unbelievable, but it tells you, I think, to me,
something's happening.
Well, and I have to look at media, whether it's social media, TV, whatever. I don't even know that when I was 10-year-old, I even understood the concept of suicide.
I think they're not out playing.
I wouldn't say it's that simple, but I appreciate your saying that.
Comment, low-grade depression can be difficult to handle as it is more hidden and can be long-lasting than acute depression. What do you think of that? Low-grade
It's
chronic.
very true. So dysthymia is one of the terms we use for that two-year period, kind of below a major depression in terms of symptoms, but very difficult to treat. It's true, and the worst thing about that isn't protective of a major episode of depression overlapping on it.
So very quickly, suicide in the elderly. I heard the highest risk for suicide is the elderly man who lost his wife. We've got 10 seconds.
Again, many risk factors, very hard. They're living in isolation. Often no one is aware of how they're feeling. And you know what? Their life has narrowed down to very few people and very few opportunities. Be aware. If you have family members, father, mother, aunt, uncle, reach out to them, make sure they're doing okay.
Bring them a casserole. And now for the winner of tonight's Prairie Doc quiz question. Well, all the things that follow with that.
Yeah.
True or false? Until 1961, with the diagnosis of depression or suicide in Great Britain, it was against the law to attempt suicide because that act was a sin. True or false? True. And the answer is sadly true. It was Bill Johnson who answered the question correctly. Thank you, Bill, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Have you heard? The Prairie Doc has a radio show. Listen to your local radio station for Prairie Doc Conversations. This program features physicians and other health professionals discussing various medical topics important to you and your family. Ask your local radio station if they broadcast Prairie Doc Conversations.
Thank you for listening. Until next time, stay healthy out there, people. Years ago, a family brought a 25-year-old farmer into the emergency room with a gunshot hole over his heart and with no pulse or breathing for more than 10 minutes. It was a self-inflicted wound, and this young farmer would farm no more. The family was beside themselves with loud and sorrowful wailing that wrenched my soul. They told me that the impending harvest looked poor, the loan was coming due, and he had been isolating himself, drinking more and getting angry at every little thing. They had no clue he was at risk of suicide. Sure, he was a little down, but not this. He picked a permanent answer to a temporary problem. Significant thoughts of suicide occur in 1 of 4 women and 1 of 8 men. Although there are more attempts by women, more deaths occur by men. In 2017, there were 1.4 million attempts and 47,000 deaths due to suicide. And despite these high numbers, the money invested in depression and suicide research is sadly way low. Risk factors for suicide include family history or prior experience of depression or manic depression, a history of being abused or being an abuser, excessive use of alcohol, sleeping pills, or substance dependence, a recent emotional loss, or a significant medical illness. Also, there is higher risk during local epidemics of suicide in youth, especially on reservations. Sometimes depression and suicide have no reason whatsoever. How can any of us help ourselves or a person at risk? First, remember, it never hurts to ask, have you been thinking about suicide? Those words will not bring it on, but could encourage the person to find someone to give life-saving assistance. If you sense there is an emotional downward change happening, encourage that person to get help. If a depression is milder and not at the suicide level, non-medicinal therapy can give relief. Examples abound, such as a daily 30-minute walk, regular interaction with friends and family, and the regular opening of one's heart to spiritual connectedness. If more help is needed, talk with your physician or care provider and consider medicines that effectively work for depression. Although 2/3 of people with depression do not seek or receive help, when the 1/3 who do get help are treated, 4 out of 5 of those folks are better in a month. Get help if needed. Finally, if you are in the crisis, call the Suicide Prevention Lifeline at 1-800-273-TALK or 8255, which is available 24/7. Please don't choose a permanent answer to a temporary problem. A big thank you to Matt for volunteering to come to our studio in Yeager Hall on the campus of South Dakota State University and add his experience and knowledge to our discussion tonight. It's always an informative evening when you join us, Matt, and also exciting and fun. If you would like more information about this program or to see more episodes, please like and follow us on Facebook or visit us at prairiedoc.org. There were many great questions we were not able to get to during our broadcast time. We will continue to answer those questions on our Facebook page following the program tonight. Go to the Prairie Doc Facebook page. We'll be there shortly after the broadcast ends. So tonight, right now, 3 minutes. This additional segment will also be posted on our website, prairiedoc.org, in the coming days. Once again this year, South Dakota's state capitol turns purple later this month to honor those who have died, survived, provided care for, or lost loved ones to pancreatic cancer or any cancer. The event begins at 3 p.m. on Sunday, October 27th at the Capitol Rotunda and Pier. Dr. Joshua Renicky, a pancreatic cancer researcher at South Dakota State University, will be the guest speaker. Music will be provided by the T.F. Riggs High School Chamber Choir, and I'm going to even lead a little bit of singing there this afternoon. This is the 5th year for the ceremony, designed to bring awareness to all of those impacted by any type of cancer. That does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
Put a Band-Aid on a cut, it is obvious, but sometimes things happen without an intuitive explanation. It is Halloween, and we explore supernatural medicine. Next time, On Call with the Prairie Doc.
On Call with the Prairie Doc is very important to a lot of people in this area and in this region because it communicates a lot of very valuable information on healthcare. This project takes dollars. We have a great foundation called the Healing Words Foundation that oversees this whole operation and is responsible for some of the fundraising to promote these programs. So the website is prairiedoc.org, O-R-G, prairiedoc.org. Go there, donate if you're so inclined, and we thank you very much.
Major funding for On Call with Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with ongoing support of these individuals and institutions,
Brookings Health System,
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
American Academy of Family Physician Foundation and South Dakota Academy of Family Physicians,
Black Hills Medical Society,
Aberdeen District Medical Society,
Sioux Falls District Medical Society,
Brookings Madison Flandreau District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
and Swiftel Communications.